Hello, friends. Welcome to fifth discipline webinar hosted by SIOP Global Health Network and SIOP Discipline team. So we have a very important topic today, acute lymphoblastic leukemia, strategies to reduce relapses in low resource settings. We have this session moderated by our two well-known experts in leukemia and oncology, Dr. Jelena Lazic from Serbia and Dr. Kirril Kirgizov from Russia. So we have two speakers. So just to introduce you about disease-specific portal for learning and networking. This is SIOP GHN's initiative to provide additional learning avenues to SIOP members. It's a learning forum on various aspects of care directed at common curable cancers. We conduct sessions on case-based discussions, diagnosis and referral pathways, access to care, advanced diagnostic and therapeutic modalities. So we invite SIOP members with enormous experience and expertise as disease expert. And of course, this plan is enhancing SIOP membership engagement as well as contributing to professional nurturing of SIOP GHN and SIOP members. So you can see the QR code taking you to SIOP Displan page for further information about Displan team and what we are doing right now and what are our plans. So we are in the pilot phase of this project. It's started in December 2024. It will go on until the next month. So basically, the aim is to globalize the already existing efforts on disease-specific learning. Discipline team has coordinated Education Day in SIOP Asia 2025, just concluded in Riyadh, Saudi Arabia. So our ultimate goals are to expand the project to non-English languages to engage global representation, connect with other projects within SIOP and SIOP continental branches, and actively interact with key global stakeholders and childhood cancer initiatives. So we had four very successful, very interactive webinars previously. First two were on neuro-oncology. You can see the speakers from around the globe, the disease experts. Then we had a very well-attended session on Hodgkin's, and the last month was Wilms tumor, and this is on ALL. So all these sessions are being recorded, and the recording is posted on SIOP YouTube channels. You can see the SIOP YouTube channel recording link. And we would have the next session on retinoblastoma in May 2020, 22nd May 2025. So just recently, as I said, Psyopatia was concluded. It was 12th of April, the Education Day. We would had 6 sessions on WHO index cancers, each session of 2 hours duration. One track was on hematologic malignancies, and the other track was on solid tumors. So we had more than 200 participants for this Education Day. And the consistent point was the interactive discussion and engagement with the audience, because every session we had to close forcefully because there was endless discussion during the question and answer session. So people want to get engaged and want to learn from the experts. So we had experts from all disciplines on these diseases, as well as it was international, as well as the local faculty contributed as moderators and the presenters. So this is the last group photo of that Education Day. You can see some renowned speakers, international experts in this. About some housekeeping instructions. So for the audience, the participants don't have the right to microphone, but of course they can put their questions at any point in the Q&A box. The text answer will come from the experts if possible, and some dedicated question and answer time after the presentation. We will go as a live answers to the questions. After the session, there will be a survey sent to you on your email addresses, and please give your feedback about this plan, and the certificate of attendance will be provided those who will submit their surveys. Thank you so much, and let me hand it over to Helena for moderating the next part of the session. Thank you so much.
Thank you, Sagir. As you nicely put it out, it is very important to educate in both levels, the young ones and also the seniors ones. We always need to repeat and regain our knowledge. And this is why we keep on our model to present an interesting case by the younger members of our community. And then all together we can discuss the case and proceed with presentations. Today, I'm very happy to introduce our young and very promising pediatric hemato-oncologist, Jelena Konstantinovic, who will present such an interesting case, and I invite you all to discuss about it. Jelena, the floor is yours.
Thank you, dear professor, on this beautiful introduction. Now I'll share my screen with you. Okay. Can you see it all?
Yes, proceed.
Okay. Dear colleagues, I'm very happy and excited to have the chance to present a very challenging patient of ours. The patient I'm about to present is a 16.5-year-old boy who presented to us at the beginning of the COVID pandemic in March of 2020 with a 2-day history of high-grade fever, epistaxis, headache, abdominal pain, and hypertension. CBC showed hyperleukocytosis and thrombocytopenia with 80% of blasts in peripheral blood smear. Biochemical analysis showed elevated levels of uric acid, LDH, CRP, urea, creatinine, as well as liver transaminases. Chest X-ray was normal, while abdominal ultrasound showed hepatosplenomegaly. We performed bone marrow aspiration. Myelogram showed predominance of blast with 88%, L1 morphology consistent with acute lymphoblastic leukemia diagnosis. Flow cytometry immunophenotyping showed early to cortical T leukemia, while molecular genetics showed CLTAL1 rearrangement, and there was no infiltration of CSF. Treatment was started immediately according to ALIC BFM 2009 protocol, and due to the hyperleukocytic presentation, prednisone dose was started at 0.1 milligrams per kilogram alongside with tumor lysis syndrome prevention. On day 2, boy developed high-grade fever, his respiratory rate increased, and he had one episode of oxygen desaturation. So given the presence of fever and newly developed respiratory symptoms, we performed chest X-ray, which showed mediastinal widening, prompting a chest CT, where we saw multiple ground glass opacities consistent with bilateral atypical pneumonia. So this represented a complex diagnostic dilemma to us due to the wide range of potential differential diagnoses. So the question was it pneumocystis pneumonia, invasive fungal infection, leukostasis, SARS-CoV, pulmonary edema, or hemorrhage? We took the blood cultures, PCR test for SARS-CoV, fungal serology, and empirical broad-spectrum antibiotics and antifungal therapy alongside with oxygen supplementation were initiated. Considering that the boy had developed DIC, fresh frozen plasma was administered. A follow-up CBC showed a further rise in leukocyte count, prompting an increase in prednisone dose now to 20 milligrams per square meter. To ensure a quick diagnosis and to help guide further treatment, we consulted international experts, some of whom are here with us today. On day 3, respiratory symptoms worsened, oxygen support and diuretic therapy were intensified, while the oral fluid intake was restricted. We performed controlled chest X-ray, which showed clear signs of progression pulmonary infiltrates, and the leukocyte count continued to rise. So this led to another escalation in the prednisolone dose, now to 60 milligrams per square meter. On day 4, blood cultures, PCR tests for SARS-CoV and fungal serology returned negative. And despite aggressive antibiotic and antifungal therapy alongside with oxygen supplementation, the boy's clinical status didn't improve, and the leukocyte levels remained elevated. So due to the lack of clinical response, we decided to escalate the treatment once again. Prednisolone dose was now increased to 90 milligrams per square meter. And according to our protocol, the first dose of IV chemotherapy is given on day 8, but we decided to give it on day 4. And that same day, a significant drop in the leukocyte count was observed. From that point, the patient remained afebrile, his respiratory rate decreased, and the oxygen therapy was gradually withdrawn. We performed controlled chest X-ray, which showed improvement. Given the patient's good general condition and the gradual decrease in the leukocyte count, we decided to maintain the same dose of prednisolone for 1 more day. So his further clinical course revealed on day 8 good prednisolone response. On day 15, bone marrow was hypocellular with MRD of 14%, classifying the patient as high risk. On day 33, both morphological and molecular remission were achieved. Regarding treatment-related toxicities, during the induction phase, pancytopenia was observed following the introduction of purinetal into the therapy, although TPMT testing was negative. During the consolidation phase, he had developed oral mucositis, few episodes of febrile neutropenia, sepsis, and delayed methotrexate metabolism. Genetic testing was subsequently performed, revealing a mutation in CLC10B1 gene. During the induction phase, he had developed vincristine-induced neuropathy. The treatment was completed in March of 2022 with minor delays and omission, and we omitted just 1 high-risk block. This is our protocol scheme. And together we celebrated his graduation and his beginning of the parenthood. And I want to say heartfelt thanks to all the dedicated and hardworking physicians listed on this slide who were involved in the complex decision-making process throughout this case.
Thank you, Jelena, for a very short and efficient presentation of our complex patient. And I will just use a few minutes. If you can get back the slide, please. Thank you. Because we come from Europe, Martin and myself, and we highly appreciate the networking and collaboration. Europe is the oldest but a small continent who is packed with many small countries. And without that, we will not manage to make such a successful cure rate in children without the communication. In that very moment, since the pandemic started, there was an initiative from Czech Republic, from our dear colleague, who invited us to gather our experience on newly diagnosed COVID patients. And when this patient was admitted in our ward, I was free to contact our colleagues, and all of these listed people responded immediately with their suggestions. And sharing the dilemma when you're in stress, we can all only appreciate that. One of these colleagues is the next speaker in our webinar, and this is the person that I personally learned a lot from. Martin Schrappe was the chair of German Pediatric Hemato-Oncology Society, was also the president of BFM group, which is the largest European group for treatment of leukemia and lymphoma, and was also one of the first SIOP Europe presidents. And I'm really happy that you are today with us. So Martin, the floor is yours, and please do continue.
Thank you very much, Jelena. This is very, very nice. May I pose a question to the previous speaker? Because I was wondering what did make you decide to use vincristine daunorubicin on day 4 instead of, for example, cyclophosphamide, because it's quite effective in T-cell leukemia as well. And my second question is, I missed it probably, was the patient now SARS-CoV-2 positive or not?
Jelena, please.
Yeah, I didn't understand the second part of the question.
Was the corona infection proven or not?
Oh, he was not proven.
Was
No,
negative.
He was not. Yeah, he was negative, COVID negative.
And the other question regarding the cyclophosphamide instead of vincristine daunorubicin, was it discussed?
Was?
Yeah, yeah, it was discussed, but due to his clinical response to he didn't respond to antibiotics and antifungal therapies, so we thought it was leukostasis, and we decided to give the IV chemotherapy before the day 8.
And
No,
the
that's
question was
perfectly fine.
why vincristine and daunorubicin instead of cyclophosphamide?
Exactly. Yeah.
Please.
Okay, maybe I can
And-
try.
Yeah.
We wagged really a lot, and the idea was just to push the regular protocol. As you know, cyclophosphamide comes with 1B, so our idea was just to shorten to stick maybe closer to the protocol. So I think that was the major decision that was made.
You know, I'm not saying it's wrong. I'm only saying I'm only reflecting our experience. We feel that in T-cell leukemia with hyperleukocytosis, cyclophosphamide can be very helpful, and we have often done it and recommended it to use it before day 8. But vincristine daunorubicin, of course, is also very effective. And regarding the question on leukapheresis, we basically never do it anymore. With the prophylaxis of tumor lysis syndrome and sometimes using chemotherapy early on, it's not a real issue anymore. In ALL, in AML, this is different. Sure.
Yeah, the same is in our center, but also I think that was nephrologist's dilemma, that cyclophosphamide potentially can harm the kidneys in this
Yeah.
situation, and that's why maybe we stick with vincristine and daunorubicin.
Yeah. That's good. That's good point. Okay, thanks very much for inviting me to this webinar. I'm very glad to present here, and I try to keep my time. I will, Jelena promised that I keep my time. I hope she's right. Thank you, Jelena, for this very kind introduction. I need to mention as well that Jelena and I, we have been doing courses inside Europe quite often, and it was always a very positive experience to work together with younger colleagues. Today, this is a little bit different, and therefore, I'm not showing you basic principles of ALL in general. I try to discuss strategies and also to give at the very end a brief update of what we are planning in the next future. So here are my disclosures, not very interesting. And this is the title of my talk. And I'm very happy that I could use this document. Jelena knows it very well, the European Standard Clinical Practice Protocols. And one of the first has been on ALL. And this is the basis for my talk today, because I think it's a very useful document and you can obtain it. And I will give a slide at the end of the presentation in which you find all the relevant references together. And in the when this is put on the YouTube channel, you can write them down. ALL is not the only one which is in this program of standard guidelines for pediatric malignancies. You see the list of tumors here on the slide. And I think most of us have been very happy to work together with young colleagues who developed these protocols and treatment guidelines. They are not considered to be to replace ongoing studies, but to be used when randomized frontline trials are not available, and when you need to have a standard approach to treat ALL or any other malignancy. Here's the link. The document on ALL can be obtained from SIRP Europe. This has been prepared by Thomas Szczepanski, Mireia Ampatitsou from Greece, and Giacomo Gotti from Italy, together with Janine Stutterheim, who is sharing now the Interfund 21 trial. And this has been reviewed by some old guys like me, Andrea Biondi, Valentino, and the young lady, Veronica, on behalf of SAMP. I'm mainly talking about Philadelphia chromosome. Sorry, I want to put on the pointer here. Where is it? But this is different here. On Philadelphia chromosome negative ALL, but I will also comment briefly on the Philadelphia positive ALL and the infant ALL at the very end. It's not proceeding anymore. Very strange. Here we go. So basically, this document and this protocol is based on a number of protocols and studies, and in particular, AOBFM 2000, AOBFM 95, ALIC 2009, the most recent AOBFM 2017, and ALIC BFM 2002. And for the special groups, it was the Interfund 06, which has been used to develop this protocol, and the SFAL backbone to develop the part on Philadelphia positive ALL. And this guideline is considered to be very useful also in countries in which not all the high-end technologies are available. But before I go into the details, I really would like to remind everybody one needs to set clinical priorities when you go into diagnostics and treatment of ALL. And I always think this is the most important part because you can make the biggest mistakes at the very beginning of an ALL treatment. So you need to ensure clinical stability by providing supportive care if needed. You need to check coagulation, and we have seen in the patient that has been presented that this can be heavily deranged, as in this T-cell leukemia. Pulmonary function is an issue, renal function, the anemia and the platelet deficiency is a big issue. And I would limit the lab tests at the very beginning before establishing the diagnosis. Sometimes you need an emergency blast reduction, but usually this can be done by steroids, and you don't need leukapheresis. You need to prevent tumor lysis syndrome because this would prohibit the further treatment a lot. And then you, of course, need to do the complete diagnostic workup, in particular to define extramedullary disease. For that, you may need ultrasound and X-ray or CT scans, and to make sure that the patient has a well-defined CNS status. That's the most important thing. And then finally, of course, cytomorphology, peripheral blood and bone marrow. This is the best technology to get a quick diagnosis, and then, of course, you need flow cytometry to determine the immune phenotype. Also, to determine the MRD marker if you use flow for MRD detection. Finally, nowadays, genetics play a more important role to define risk groups, and therefore it's ideal if you collect specimen immediately and send them to a well-qualified lab. I think you're familiar with the main subgroups of genetic subgroups. Some of them have favorable genetic risk features, such as patients with hyperdiploidy or ATV6 ranks 1. Others have very unfavorable, fortunately rather rare constellations, such as hypodiploidy, came to A gene rearrangements, or IM21 if the patient is a poor responder, BCR-ABL, Icarus Plus. This is it is a new important subgroup. And in T-cell leukemia, we also have a number of genetic abnormalities, but it is not so easy to determine which are prognostically really relevant in which direction. This is not the main topic for today's presentation. I think you need to employ what is available in your country. And sometimes people have everything available if they have the resources. Otherwise, you can do very well with FISH and RT-PCR or MLPA. but many centers still use the banding technology to determine genetics. Everything is fine as long as the labs who do it are well qualified to do it. This is an example from that guideline, how to use genetics to determine the risk group based on genetics, of course, in combination with response. And of course, when you define patients with certain rearrangements, you may not need to do additional genetic testing. But if this is not the case and you are looking out for Icarus Plus, for example, then you need to continue. And you need to do a little bit more to make sure that the patient is eventually entering the right risk group. From the BFM point of view, the response evaluation is probably the most important part of your workup. It's not something you do on day one, it's something you do during the course of the treatment. It's potentially the prednisone response in peripheral blood on day 8. It may not be needed anymore in precursor ALL, but it's definitely still very helpful in T-cell leukemia. The case that was just presented, of course, was an exception because there the counts were rising during the prednisone treatment. And then, of course, you have to deviate. But then we have MRD, and MRD is now basically well known to everybody on day 15, on the end of the induction and the end of consolidation. And there are different technologies available. And again, you see it listed here. You have to rely on well-organized labs who participate in quality control rounds to make sure that the diagnostics are done on well-established guidelines. And if you put this all together, the clinical points, age, white blood cell count, genetics, and response, you are in a very good position to do the right risk group stratification. And this is basically here derived from the ALIC 2009 protocol, where the initial parameters are combined with response based on flow cytometry on day 15 and on day 33 to assign patients to either to the standard risk group, which is rather small, to the large intermediate risk group, or to the high risk group. And nowadays, of course, one is trying to integrate genomics and PCR-based MRD more and more, but the general principle of this stratification is still completely valid. So in this guideline of ESCP, the following schema is recommended. After an induction therapy phase with 2 or 4 doses of anthracyclines based on the initial risk presentation, consolidation is done in all patients with protocol 1B. Everybody is familiar with that. And then different doses of methotrexate, 2 grams or 5 grams, or in poor responding patients, or in patients with unfavorable genetics, high-risk blocks are recommended to be followed by delayed intensification. Many people ask the question, why is delayed intensification so relevant? Because the toxicity is quite relevant. And I will show you an example which was also surprising to us. And the big question is, can one reduce the intensity of the treatment in that phase? And we have investigated this on a randomized basis here, in which we basically took the whole delayed intensification and cut everything down by 50%, more or less. And we were very much surprised by the results that every subgroup, you see the subgroups here, I hope it's not too small, even in patients who had rather favorable characteristics, always the more intensive delayed intensification was more effective. Overall, it was highly significant. There may be some subgroups in which this is not the case. One example may be the ETV6 ranks 1 positive patients who, if they are in the standard risk group, which means they have responded very well, they may not need the more intensive delayed intensification. But unfortunately, we could not show in that study that a reduced intensity provides the same efficacy. What about cranial irradiation? This is a big issue in many discussions and many study groups. And right now, I think this recommendation here is very feasible. In young children, we need to avoid cranial irradiation because the late effects are so dramatic. In patients over 4 years of age, there is a small subset of patients in which this may still be advantageous. And this is patients with T-cell leukemia. Here you see it, T-cell leukemia, initial white blood cell count over 100,000. 12 gray of cranial irradiation is probably superior in reducing relapses, both systemic and CNS relapses. And of course, in patients with CNS3 disease, if they're more than 4 years of age. This is, of course, a moving target and under discussion, and I'm aware of the fact that some study groups have stopped it completely. One needs to remember, however, that this is also depending on the intensity of the intrathecal treatment and the application of pulses, for example, during maintenance. So one has to find the right way here, depending on the resources available. Some comments about treatment components. You're aware of the discussion on prednisone and prednisolone. The dose and induction can be 40 or 60 milligrams. BFM has been using 60 milligrams all the time together with the prephase. We have stopped to use pulses of prednisolone in maintenance. Dexamethasone is very effective, but also very toxic because it increases the rate of infection severely. Therefore, we stopped it again. Vincristine, the standard dose is the same everywhere. I'm not convinced about the vincristine steroid pulses in maintenance, but some groups continue to use them. Asparaginase here is a big issue because the formulation is important and the source of the drug. Unfortunately, you may remember the statistics from PSYOP. They have investigated this carefully. There are some sources in which the product is completely inefficient, and of course, then it's ineffective. Ineffective in terms of preventing a relapse. So this is a very crucial point. Right now, I know that PSYOP together with WHO is trying to make sure that pegylated asparaginase of good quality is made available for many more countries than at the moment. I hope this will be effective. The anthracyclines play an important role. It's only a question of how much do we really need. Cytarabine, I think, has a role. 6-MP, theraguanine, certainly important for consolidation and for maintenance. And methotrexate, this is also a big issue. Which dose IV, how many doses intrathecally, and the oral dose in maintenance is also a little bit different between protocols. I think in terms of IT therapy, 11 to 15 doses should be sufficient in the vast majority of protocols. Toxicity is a relevant issue. Here, just a few examples. This is the BFM backbone with protocol 1AB, protocol M2AB, and maintenance. You look at pancreatitis over the course of treatment. And of course, there are certain phases in which asparaginase is being given. And of course, there we see more pancreatitis. Not so much if you do extended PEG asparaginase treatment as we have done in our 2009 study. In the high-risk group, the picture is different because we use high-risk blocks based on, not based, but using also a lot of asparaginase. To me, most important is, however, this and the following slide, in which you can see that patients over 10 years of age are at a much higher risk to develop pancreatitis if they are treated in that age groups, in these two age groups. And this reflects also the reality of adult patients or young adults with ALL who are being treated with asparaginase. they're facing pancreatitis much more often than younger children. When we look at thrombosis in ALL treatment, this happens not only in induction, but also afterwards. And again, it happens more frequently in elderly kids, adolescent kids. Infections is another big issue, and we have investigated this in detail. It's not so frequent in the induction phase, but then in the BFM-based protocol, it's more frequent, again, in adolescents in the more intensive reconsolidation blocks of the high-risk group. So the high-risk group and the adolescents are at risk, and they need the largest amount of attention clinically. Some final comments on Philadelphia chromosome-positive ALL. You're probably familiar with this randomized trial that COG and BFM have done together. And here we have a randomization of the BFM backbone and the COG backbone in terms of chemotherapy while using the same TKI, imatinib. High-risk patients, those are the patients with poor response by MRD. They all received the same chemo backbone. This study has finished last October and is not randomizing anymore. And right now, it's recommended to use this arm because it seems that the toxicity in the COG backbone is much lower than with the high-risk blocks. I think it's a good message and important that this was investigated on a prospective basis. Interfund, another comment here. You're aware of the small pilot study using blinatumomab after induction, which was very effective. That's why blina is used here again after induction therapy. But in this new protocol, Interfund 21, it's also used a second time instead of MAMA chemotherapy. And this study is ongoing, has recruited roughly 40 patients up to now, but needs some adaptations because at the same time when immunotherapy has been introduced, also the dosing of chemotherapy has been changed quite a bit. And I heard recently that they need to adapt the chemotherapy dosing recommendations because it's sometimes a little bit too toxic. But I cannot go into the details here because it's confidential. Some final remarks regarding the use of blina. You're aware that I've been sharing this study, which was an international study, which has stopped recruiting patients for randomization in August 23. We are coming close to the evaluation phase. And the focus here regarding blina was in the high-risk group. By the way, Down syndrome ALL patients always receive blina here. This was a randomized study question. And right now we are facing the big question, which is different from the US, because in Europe it is not freely available. The insurances are very reluctant to pay for it. So the reimbursement question for this rather expensive drug is still open. This is the schema in very simple terms. The yellow boxes here is blina in the high-risk group, randomized versus high-risk blocks chemotherapy based. And here on top of chemotherapy, we also used blina one cycle in medium risk patients. Standard risk patients did not receive blina. So in the high-risk group, this is the first study in which chemotherapy was replaced by 2 courses of blina, 1 and 2. If they did not respond to blina, they, of course, were switched back to chemotherapy, which happened very rarely, by the way. And I've shown these results, the interim results on toxicity during the ASH meeting. It is really stunning to see that the experimental arm with blina never showed any life-threatening adverse events in that phase. That is very, very pleasant and of course, encouraging because the toxicity profile was one of the main questions in that study. The other question cannot yet be answered. In Down syndrome, we stratified as in non-Down syndrome. I'm not going to those details, but when patients ended up in the high-risk group due to poor response, for example, they did not participate in the randomization of bortezomib, but they received always 2 courses of Blina instead of the rather toxic HR2 and HR3 blocks. And here is an outcome analysis of this non-randomized part. And it's very encouraging if you compare the 2009 study and the 2017 study, Down syndrome, high-risk patients only. For high-risk Down, this is a very nice outcome of a 3-year event-free survival of 84%. Well, let's see what will be the final result, but we feel encouraged that this replacement of chemotherapy in Down syndrome patients was no mistake, even if we excluded the poor responders and the Icarus plus patient. The only thing which needs attention is the side effects in Down syndrome ALL when using Blina. One of them is seizures, and they also did occur later on when we used levetiracetam. And the other one, which is not on this slide, is potential threatening infections later on in maintenance or even after maintenance, because these patients have prolonged and sustained immunosuppression. So what is the main difference between the wonderful COG study, which has provided fantastic results, and I'm sure Cesar will talk about it. They have used Blina in standard risk high and high risk patients. There are some relevant differences. The risk stratification is different. They use the NCI risk criteria, which we don't. They have been using Blina on top of chemotherapy, while we have been replacing chemotherapy. And that means that only some of our medium and high-risk patients would meet the patient characteristics that were part of the COG study. Nevertheless, this is one of the most important studies for the next few years for all of us. So to summarize, we performed the first trial in which high-risk patients received Blina instead of chemotherapy. So we replaced the chemotherapy and did not add it on. We're awaiting the outcome results. We only know that the toxicity profile is more favorable, and we hope that the clinical outcome results will be available during this or the next year. In Down syndrome ALL, we continue to use Blina, and this is reimbursed by the insurances because it's so safe and also seems to be very effective. What do we do in 2025? We have changed our definitions for standard risk patients to form a group of patients who have an event-free survival of 5 years of more than 95%. And you see it here. It's basically all the favorable genetic subgroups in combination with very good response. And here we do not use Blina because these patients do already so well. In medium risk patients, we are now awaiting the final decision by the insurance industry to introduce Blina, just like COG showed it, on top of chemotherapy, 2 cycles. The only thing which we will make sure is that everybody measuring immunoglobulin levels and substitute if needed. And in the high-risk group, the same will take place until we know if the randomization has been safe and effective, replacing these 2 cycles of chemo by Blina. Then this will look different, of course. Here's the relevant literature. You can write them all down when you have the slides. I think one study is rather important, this one, which may not be known to everybody, because we found out more or less by chance that the additional intrathecal methotrexate given to patients with CNS2 status also caused serious infections significantly more in the group of CNS2 patients who had 2 additional IT methotrexates in induction. Therefore, we have stopped to do this because we don't want to take the risk of life-threatening or fatal infections. There are also, by the way, some very, very nice comments here from Raul Ribeiro and Valentino Conta on the ALIC 2009 study, which is a large international endeavor, and they have introduced some, I think, very practical, resource-oriented strategies, how to use the resources most efficiently and how to develop research in ALL, depending on the environment. And finally, I need to mention the ALIC BFM 2002 study that was published by Jan Stary et al. In JCO and was commented also very nicely by Steve Hunger, who also gave a very good educational at one of the ESCO meetings. Finally, I would like to thank my co-workers in Kiel, in the reference laboratories and in the task force and study committee. And thank you for your attention.
So Martin, thank you very much for sharing this detailed data, historically, and those ones that we put our head and eyes into the future. And we had 3 questions that I would like you to address regarding the presentations and your comments about it. One came from Prasanat. I hope I said it right, pronounced it right. What's the group's take on leukapheresis for such as children with symptomatic hyperleukocytosis?
Well, we approached this question at the very beginning. Leukapheresis, in my mind, in my experience, has not anymore a very important role. There may be a few cases in which it's useful, in particular in larger patients or in patients in which, for some reason, cytoreduction is not possible. But usually in ALL, I think it's not needed anymore because with the use of steroids, cyclophosphamide, vincristine, anthracycline, you can reduce any count. Even in patients with 1 million leukocytes, we do not recommend leukapheresis, except if the counts, despite this intensification, would be rising, but I've never seen it.
And the 2 questions that I believe come from the same participant, which is anonymous, which he or she commented they utilize DL asparaginase for cytoreduction in similar situation to control fall in TLS with minimal risk of TLS, which is true, and commented right afterwards that maybe we don't use cyclophosphamide in induction because it is a drug used in consolidation reserved for resistant blasts. Theoretically, we prefer not to use it in TILL hyperleukocytic one. Also, the comment was we use LASP for hyperleukocytosis. So your comment on asparaginase and hyperleukocytosis, please.
I have no experience with that. I've never heard about it. That asparaginase is very well suitable for cytoreduction, but I'm not saying it's wrong. It's simply something which we have never done. I also would be a little bit concerned to give it in patients with hyperleukocytosis because asparaginase causes hepatotoxicity, and this is not something you want to have at the very beginning. This is one of the big advantages of cyclophosphamide and together with the steroids, that hepatotoxicity is rather rare. Asparaginase can, in addition, also cause coagulation problems. And if you have started with coagulation problems and you add asparaginase, this may cause severe problems.
I agree, and I will just remind our participant that DIC score in our patient was 6, so adding
Exactly.
asparaginase won't be the cleverest move. Yeah.
Yeah.
So there is another question regarding asparaginase. Is there a good replacement when patients are allergic? I think we all know the answer, but please do it formally.
Yes, this is a good point because I'm aware of the fact that the E. coli asparaginase, which is used by many countries still, gives you the opportunity to use in case of allergy, then the pegylated product, and the third product, then ervinase as an alternative. If you start with pegylated asparaginase, it doesn't make sense to go back to E. coli. You only have ervinase available, and it's very, very expensive. And the few other alternatives I'm not too familiar with, and I'm not sure if one should recommend it. So let me turn the question around. We need to look out for the robust evidence that asparaginase after induction is really so essential. And I would raise the question if the allergy takes place in delayed intensification, I would not spend too much money and too much time on finding an alternative asparaginase. I would just skip it. What we have seen when we introduced pegylated asparaginase, however, is that the rate of hypersensitivity dropped from 35% down to 6%, 7%. And this is something which was completely unexpected, but very helpful, of course, because very few patients only need ervinase anymore.
Thank you. And I see that we have a genetic expert, and thank you for that. It's Saima Alvi, who thanked you for the great presentation and asked, how do you treat ELZF1? And in those patients, she added another question, were deleted and not deleted, high-risk ILL. Is there any role of extending maintenance therapy as seen in a Dutch experience?
We have been puzzled by these results as well, to be honest. And I think I cannot really answer the question good enough. It's possible that extended maintenance may make a difference here. I think this should be proven on a prospective study. This is, for me, it's not, the databases is not big enough.
And what about genetics?
In terms of what?
Of Icarus in resistant IL?
In resistant cases, you mean?
Yep. I don't think it.
Well, as shown by Martin Stanola, Icarus Plus is associated with poor response to treatment. Icarus by itself is a weak prognostic marker, but not as strong as Icarus Plus. And this has been shown now by several study groups, not only by ours. But again, the prognostic impact of a single genetic marker completely depends on the backbone of treatment. Therefore, it is very difficult to make a general statement.
And another question from Sadia Anwar is, what is your recommendation for resistant TLL in the setting where nelarabine is not available? That's a very
very good question and a very difficult question.
Yep.
Because first of all, even if nelarabine is available, it's not guaranteed that it's effective. If you have a resistant patient who is not responding to the usual components of chemotherapy and you have no access to experimental therapies, it can be very difficult. You have to try very aggressive chemotherapy to put the disease down and to proceed to transplant, because allogeneic transplantation in T-cell leukemia is one of the few indications in which the superiority of transplant has been clearly shown.
And we have time only for one more question live. What is your experience with asparaginase-induced thrombosis? Do you recommend any prophylaxis? And another thanks for your presentation.
We have been running a randomized study comparing 3 types of prophylaxis, and there was a clear result. Low molecular heparin as well as antithrombin 3 in induction provided a reduction of thrombosis. The current practice in AOBFM is to recommend prophylaxis in induction, maybe up to day 15, day 50, I wanted to say, and maybe also in delayed intensification in the first phase, using low molecular heparin, because the safety profile of the low molecular heparin was a little bit better than 83. But we only recommend it in patients who are more than 6 years or more than 10 years of age, because small children do not like these sub-Q injections. And also their rate of thrombosis is so low, it does not seem to be justified.
So thank you very much for the presentation and your efforts to do the prompt answering to different questions. And I would like now to pass the microphone to Kirril. First, Kirril, thank you for joining us. We are happy that we have you today. Kirril is a very experienced transplantologist in both hematological and non-hematological malignancies. And he will introduce our next panelist, very well person to all of us, and then lead the discussion afterwards. Thank you.
Thank you so much. It's my great pleasure to be here. And of course, it's a great honor to participate in this kind of Zoom meeting with such important persons in pediatric hematology and oncology. And of course, it's a great pleasure for me, especially as a part of BFM family, to introduce the other side of acute lymphoblastic leukemia treatment from United States, as a Dr. Cesar Nunez, who is an associate professor from Department of Pediatrics Patient Care from MD Anderson Cancer Center. And of course, he is a very important person and the author of many manuscripts and protocols. And of course, we are happy to have Dr. Nunez here presenting for our great webinar. Please, the microphone is yours. Thank you.
Thank you, Kirril. Thank you, Jelena. And thank you, Martin, for the excellent overview about the status of the ALA in Europe. I would like to make sure that you are seeing the presentation form. That's correct?
Yes, we are.
Okay, perfect. So, as Kirril mentioned, so we are in MD Anderson in the division of pediatrics. So here we are. Let me see. So what are we talking today? A good difference in outcome of to reduce the risk of relapse in ALL, recent advance in the treatment of acute lymphoblastic leukemia. I see that Martin mentioned some of them already. Where we are in BLL in the combination of chemotherapy and immunotherapy, and where we are in the TLL, and how we can use better the treatment options. So here is a global cancer distribution. Most of you know this information, but this is just to make the comment that independent of the distribution, there's several issues that here they are important because there is a fair amount of distribution in different areas of the world. Central Asia and India subcontinent, East and Southeast Asia, Africa has tremendous population. But in the moment that we look theoretical models to predict the survival estimate in childhood global cancer, and this is a simulation study that was done between different groups. The interesting situation is that when we look here, the upper panel, acute lymphoblastic leukemia, the difference is real interesting. In a disease that potentially is very high rate of cure, You see, for example, here in Africa is relatively low. Asia is improving tremendously. And the main question is that in each particular area, they are center of excellence. But at the same time, there are other centers in which the resources may not be as good. There are some limitation in their resources. Therefore, the data that is coming for survival may reduce the overall observation. Europe, North America, very good. Oceania is improving tremendously. Latin America is getting better. But how we can work it out in this? So how we can learn from this experience? Because at the end of the day, one of the things that they are important, one of the critical prognosis factors, independent of cytogenetics, independent of the molecular stuff, is what is the type of treatment that the patient may receive. And this is very important because if there is a limitation in terms of the treatment, if there is a limitations in terms of what we can do, that is going to be limitations in the results. So here is what else can we do to overcome this scenario? So what we have learned? We have learned that the improvement in patient access to clinical trials is a very critical step. We have learned that the multi-institutional clinical trials in different consortiums around the world, that is important. We have learned that the use of multi-drug and rotational combinations improve the survival. We have learned that the design of the treatment to maintain or improve cure rate, but also we are learning that we need to reduce secondary effects. We have to advocate for the access to new medications and new therapeutic methods, and also we have to reduce the non-compliant issue that in many occasions appears. So this is well known, and I think that this is the experience of the different international groups in which the survival curve has improved tremendously. But when you look and analyze the data, this is literally a logarithmic progression of the survival. Why? Because at the beginning, many minimal interventions, they were able to produce a dramatically improving survival. And once that we are reaching a certain point, you have to make sure that you are going to do some changes in order to improve the survival. And those changes may not necessarily be as dramatic as before. But for those countries in which the resources are limited, there is a tremendous amount of minimal effort. They produce huge improvement in survival. And we have to keep that one in mind. So here is the issue. In the moment that you are reaching this point, it's very difficult to improve things. So one of the critical issues here is how we can, without changing the good responses and the good event and overall survival, how we can reduce chemotherapy and minimize long-term toxicities. So this is important. But how we can maintain this survival and how we can improve, particularly when the patient has a relapse. Here is the experience of the COGs 1331, 155 hospitals. The age of the presentation was 1 to 30 years, 4 weeks reinduction following randomization. And here the reinduction was done based on the R3 protocol from the MRC. But the interesting situation, these patients, they were randomized, and they were randomized to receive chemotherapy and blinatumomab, which is a monoclonal antibody that is be engager, engage CD19 and engage CD3, and compared with the chemotherapy backbone. And the end results, they were after 2 years, the Data Safety Monitoring Board considered that there was a time in which Blina, at least the data was supporting that was producing better results, and the randomization was stopped. In one moment was considered that health was stopped a little earlier, but when you look the disease-free survival was 54.4% for the Blina chemo R versus chemotherapy alone that was 39%. That by itself, that introduced the concept that blinatumomab definitely was an important. Having said that, due to the early termination, the statistical difference was not as significant. However, when the data was analyzed with 3 or 4 year disease-free survival, and here we have the blinatumomab arm, and here you have the chemotherapy arm, what is something that is interesting, when you look here, the first arrow in the upper panel is patients that they had bone marrow plus minus extramedular disease. The 3 and the 4 year, the disease-free survival was definitely superior in the blinatumomab arm, reaching 72.7% 4 years versus 53.7%, although statistically was not completely different. However, when you look the overall survival was also maintained, but the same result with improvement that the combination was superior. Now, for isolated extramedular relapse, that is something interesting, and we have to address the situation, and we have to learn. There was no major difference between blinatumomab chemotherapy or chemotherapy alone. So the bone marrow compromise, definitely blinatumomab is an issue. So that prompted the decision, if this happened in the relapse settings, what if, based on the data from other groups, can we use in a frontline therapy? And that was part of the, Martin made a little bit of comments about that. So that was done in COG 1331, in which there was a phase 3 newly diagnosed standard risk ALL patients. The standard risk was based on the NCI criteria. And I think that for many groups or many areas in which molecular cytogenetics components, they are not really available or easily available, just 2 elements that they are coming directly with the patients, which are age and initial white blood cell counts. That will help tremendously in those low resourcing settings to make a major difference in terms of the risk stratification. So in that particular case, the standard risk between 1 to 10 years of age, and the white blood cell count less than 50,000. That's very simple. But that simplicity came later and expanded in a little more complicated based on MRD and based on different cytogenetics and molecular events. But at least for the moment, that was very simple elements that we are using in COG. There were expected 4,018 patients that they were initially enrolled. The initial expectation was around 6,700, but there was an issue for which there was only 4,000. So the median follow-up was around 2.5 years, and the overall observation was based, and I will explain a little later, in the average group or the higher risk of relapse group between or within the standard risk. So at the end of the day, this produced a randomization of 1,400 patients, which very similar observation between chemotherapy and 2 rounds of blinatumomab. So here is a simplified scheme that I try to put it in a way that will be a little simpler. It's more complicated. I think that Martin showed just a fraction of how complicated is this scheme. But overall here, we use an induction for a standard risk with only 3 drugs, steroids, vincristine, asparaginase, 4 weeks induction. And the end of induction, MRD will determine if the patient has less than 0.01 or more than 0.01%. And this is based in flow cytometry analysis. And that will simplify those that they are less than 0.01 or less than 0.1% for double trisomy 4 and 10. They will be classified as a standard risk, or they will be classified as a favorable if they follow. And here is where the risk stratification start to becoming a little more complicated. If they are CNS, 1 or 2, if they are ETB6 Runers 1 or double trisomy, if they have minimal residual disease on day 8 by peripheral blood less than 1, or end of induction MRD less than 0.01. So these go here and they receive different treatment. And as Martin mentioned, these patients, they do extremely well with very simple chemotherapy. But those patients that they are average, in which there is still a little bit of presence of MRD, how they do, or in which they have indeterminate end of induction MRD for many reasons, how they will do. So they were the ones that they were randomized to receive chemotherapy as the augmented BFN that we have done for many years, or the addition of 2 rounds of blinatumomab in the sequence of blina-1 interim maintenance based on Capisi, style methotrexate dosage, and skin, blina-2, delay intensification, again, a second interim maintenance with Capisi and maintenance. All these patients that they have high risk of relapse, that they were with persistent MRD, they were, some of them that they had persistent MRD, they were directly receiving the blina treatment, or those that they have changes in the MRD at the end of consolidation, they were randomized to receive chemotherapy or to receive the blina extended. So in general, there were 4 arms, A, B, C, and D, 2 average and 2 for high. So, and the results are relatively clear here because the randomization was stopped. I mentioned that there were around 4,000 patients. It was expected to enroll around 6,700 patients, but the decision is in one point was to stop the randomization because the Data Safety Monitoring Board determined that there was an important statistical difference with a relatively short evaluation of 3 years. The blinatumomab and chemotherapy, which is here in orange, and you will see in the disease-free survival, this is the overall cohort. This is the patient that they were standard risk average, or this is the standard risk with high risk of relapse. The disease-free survival overall was 96%, compared with chemotherapy alone, 87.9%. So that difference by cell was already maintained, independent of which group of which risk of relapse was there. The overall survival was very good, but the other critical issue was here the cumulative incidence of relapse for those patients that they received the combination blina and chemotherapy was minimal, below 5% in the range, and those patients that they have receiving chemotherapy, the risk of relapse was higher. So that definitely is frontline protocol that demonstrate that the combination of blinatumomab with chemotherapy is superior than the chemotherapy that we were using here. So now the question, there are a lot of information, there's a lot of things that are going on, but 2 things that they were coming into this place. There was no major changes in terms of the CNL relapses, and those patients that they were assigned to the blina arm, they had a little more increase of infections, not necessarily, as Martin said, life-threatening infections, but compared with the other group, because we are analyzing here a standard risk, there was a little high rate of infection. So when the different subgroups, and I hope so that this present very well for you, but I apologize if that's not the case, when the different groups, they were analyzed, what you have here toward your right is blina chemotherapy. They do better. What you have here to the left, chemotherapy alone. When you look the different observation elements, independent of the age, independent of the gender, independent of the ethnical group, independent of the CNS status, independent of the cytogenetics, independent of the MRD, in different points, the blina chemotherapy group did better. And this is one of the critical elements that is going to help us to define and redefine better treatment strategies for the future. And I think that Martin demonstrated that he's already in the process to work in different places. Now, what we have learned in MD Anderson is that our adult groups, they had by definition, larger population than what we had in pediatric. They have been using immunotherapy. They have been using blinatumomab for longer periods of time, and they have using in the backbone of the hyper-CVAD treatment. So what we have done is learning from there and adapted and start to use the different concepts of the immunotherapy in the same way that they are using for the adults. And we have several experience in which for relapse patients, for relapse BALL, we have been using combination of mini hypercival with reduced doses with condensed rituximab, inotuzumab ozogamicin, and blinatumomab for refractory pediatric BALL patients. And we have used in different, a little bit of different publications here. But just to show you that, and this is one of the plots from one of my colleagues, one of the publications that we did, is that these patients, in spite of this, with this approach of combination of immunotherapy, because many of these leukemia cells, they are going to express CD20, they are going to express CD22, they are expressing CD19. So if we have elements to tackle, so why we don't do that? So that is what we are changing slightly our strategy, and definitely many of these patients, they were able to get into complete remission, and they were able to move to the different strategies, either continuation of the treatment or going into a stem cell transplant. And obviously there are some patients that progress of disease. But nevertheless, this is an indication that it's feasible to do it. This is our standard of care. We are not using any more R3. This is our combination chemotherapy with triplet immunotherapy has been feasible, is something that is not complicated to use. But what happened with the TALL? So here we have some results in which different treatment has been used. One has been used, again, using the backbone of the BFM augmented treatment and using nelarabine for treatment of the TALL. So here are the results of this protocol in which, as you can see, there were different components. And the different components, they are patients that receive nelarabine or non-nelarabine. And in the way that the nelarabine was given was very interesting because there were 4 groups. One that received Capisi-style methotrexate with or without nelarabine versus high-dose methotrexate with or without nelarabine. Those patients that receive Capisi methotrexate with nelarabine, they receive earlier cranial radiation prophylactically. And those patients that receive high-dose methotrexate, they receive it later when they arrive in maintenance. However, the results are quite interesting, and they were somehow surprising because for the Capisi nelarabine arm, there were 91.4% disease-free survival. Capisi without nelarabine, they were around 87%. High-dose methotrexate with nelarabine, they were a little lower. They were the lowest. They were here around 85%, and the other group was 78% high-dose methotrexate with non-nelarabine. So what is interesting is that patients that received Capisi-style methotrexate, they did, in combination with nelarabine, they did better than the high-dose methotrexate when combined with nelarabine. And those that they were doing Capisi alone without nelarabine, they did better than with high-dose methotrexate. So this is a strategy that is interesting. And obviously, there's a lot of discussion about how this can be combined. They are in the process to do combination. But at the same time, what else have we learned about T cells? The other protocol that was running associated with T cells was the combination of chemotherapy. Again, the BFN augmented backbone and the use of bortezomib. So here the situation was quite interesting because for the TALL, there was no major difference if you use chemotherapy or you use chemotherapy with bortezomib. There was absolutely no major difference. So, but when you had a patient with T lymphoblastic lymphoma, the group that they used bortezomib, they did better than the group that they didn't use bortezomib. Therefore, the learning process here is chemotherapy with bortezomib is better for patients that they have T lymphoblastic lymphoma, but no for TALL. And the overall results in the T acute lymphoblastic leukemia, they were not superior to the use of chemotherapy with nelarabine. So far, combination of chemotherapy, capici methotrexate based and nelarabine, they are still superior to other combinations for TALL. Because this seminar goes to different areas, and one of the different questions that we receive in many places, what happens if we cannot use high-dose methotrexate for multiple reasons? There is no resources, there is no way to measure methotrexate levels. Of course, you can follow the BUN, you can follow the creatinine, you can follow the urine output of the patient, but there is another way that you can try to do it, may not necessarily overall recommendation. However, based on the data that we have here, this is something that you can do and is a little more accessible. So that's the reason that I bring here into consideration. Because capici style methotrexate, I apologize for all of you that they are aware of this, but on day one, it's been increasing methotrexate, and the critical issue is the methotrexate start at a dose of 100 milligrams per square meter. And every 10 days, the methotrexate will increase counts per minute 50 milligrams per square meter. Therefore, on day 11, 150 milligrams, day 21, 200, day 31, 250, day 41, 300 milligrams per square meter. What happened? There is addition of 2 intrathecals on day 1 and day 31, but there's addition of pegasparaginase on day 2 and on day 22, and that is the way that we are using right now the capici style escalated methotrexate. The maximum doses of increasing, as you are aware, is 2 milligrams. The critical issue with this capici methotrexate is there is no rescue with leucovorin. So the full dose of methotrexate is going to be active, also the doses are escalating and they are not so high. Obviously, the neutrophil count and the platelet has to be into account, and if there is a toxicity associated with this, there are some degree of reduction, and there are some ways to do combination of the elements in order to get the chemotherapy. So I think that with this in mind, what I am trying to do is to get an idea, number one, that in this moment, chemotherapy combined with monoclonal antibodies and in the induction of immunotherapy is going to be the standard of care in the different settings of acute lymphoblastic leukemia, particularly in the B-ALL arena. In the T cells, they are coming different monoclonal antibodies, they are CAR T cells that they are coming as well as in B cells, but perhaps the data is not as mature as we expected when compared with the B-ALL. So I think that with that in mind, I am going to stop, and I'm going to show you here part of the group in MD Anderson, the different colleagues and teams, and also say thank you to all the group inside of this plan, because this level of activity, I think that is producing fair amount of question and produce a lot of information for many colleagues around the world. With that in mind, so I'm going to stop here, and I'm going to stop the sharing, and I return the floor to Kirril and to Jelena.
Thank you.
So
Kirril, please.
Sorry. Yeah, thank you so much for your great presentation, and I'm really glad that so many new things you've told, and of course I hope we will have a great discussion. So we have checked that there are no new questions from our chat, but this is a very important thing because we have at least 5 minutes to have a great discussion. And of course, the type of discussion and the main question is the resource limited setting, both for diagnosis and treatment. And as Sajir mentioned before, we had a very productive educational day in Riyadh, and the most important question was about how to diagnose, how to test MRD, and how to treat in a resource limited setting. So this is major questions after these presentations. Irena, what is your idea? Maybe we could ask our great experts, firstly Dr. Nunez, about his point of view on how we could optimize and how we could do MRD testing in a resource limited setting. Should we do, or should we focus on other types of diagnosis? And about Blina, of course, because each time when we spoke about resource limited setting, we have discussions what is the best way to use Blina or not to use, because Blina possibly could have a lower incidence of infection or etc. So should we start about the diagnosis? Dr. Nunes, what is your idea about MRD testing?
Well, I think that it's quite obvious that MRD testing is very important. There is no question about it. The way that we should go, the technology to see how we can detect the MRD, that is what is going to change, and depends on the resources is going to be different. Flow cytometry, for obvious reason, is there, is a little cheaper. Perhaps centralization in some areas in which they are low settings and not so easy, but they can centralize in some specific laboratories. It's coming now the next generation sequencing in different ways, either based on the immunoglobulins and T cell rearrangement genes and or specific genes. The difference is that we can get better results to the 1 to 1 million detection using the gene rearrangement techniques when we are using specific genes, the sensitivity is a little less. Obviously, it's a little more expensive, but the other concept that is coming into place, we don't have too much global experience in this, which is the point in which we are using the level of 1 to 1 million for a specific immunoglobulin gene sequence that is detectable. When is going to be negative and what will be the meaning of that? When is going to be persistent and what is going to meaning of that? And when we expect to do it. I think that is a learning process that we are doing right now in the different groups in terms of how to analyze the data. Now, going to the point of the Blina, Blina is interesting because we have been using for courses of over 28 days in continuous infusion. Now, there are some questioning regarding T cell exhaustion. So in one particular moment, the question that we need to answer, are the 28 days necessary to do so, or eventually reducing to 14 days is going to be the same results or no, and using more frequently? We don't have the answer for those. I think that we are, in terms of the immunotherapy, we are something similar to when we were using 3 or 4 different chemotherapy agents, learning how to do it and try to make the different combination to figure out what is the one that produce better results. But I think that now the elements are there. This question of start to put it into the different groups.
Thank you. I'm sorry, we have a few questions now. I think after your great lecture, I was pretty sure that we will have it. Elena, is it okay if I will write, because these two questions are very interesting, because these questions are about immunotherapy. So the first question is overall, in the absence of stem cell transplantation, is blina be generalizable for its outcome? How do you follow the serum immunoglobulins level after blina? And the second question, I think not the same, but the same idea from Dr. Anwar. Is there any role of rituximab alone in the resistant B cell ALL?
We have been using, as a matter of fact, as I mentioned, we have been using the combination of these three monoclonal antibodies, these anti-CD19, anti-CD22, anti-CD20, we use in a specific way. That has been already some degree of published, and we are using the model of the adults. And actually, those patients that they are in relapse, they do better. They have less toxicity compared with the only chemotherapy that we were using before. So this is something similar to what Martin say in patients with Down syndrome and blinatumomab. They have less toxicity overall. And that has been our experience. So if you have a patient in which you cannot get transplant for many reasons, I think that the use of immunotherapy is going to be very useful. So the different arms are based in monoclonal antibodies. Now the use of CAR T cell is another element. We definitely we don't have time to discuss about it, but this is a completely different topic, and I think that a seminar dedicated to that is going to be useful. But there are several options that you can exercise if you don't have the opportunity of a stem cell transplant. And now the other question was?
Yeah, and the second question is about rituximab. Usage of
Yes.
rituximab in B-cell ALL, refractory B-cell ALL.
Yeah, so as I mentioned, we are using, this is part of the protocol that we are using. People argue, what is the level of the intensity that do you want to use it? In other words, if you have more than 5% CD20, I think that that is useful. And at the end of the day, we are using chemotherapy. Now we have different monoclonal antibodies. Why we don't use it? Why we don't combine?
Thank you.
That's what we are doing right now. We believe that this combination of chemotherapy, reduce the intensity of the chemotherapy, intensify slightly the use of monoclonal antibodies is very useful. We have to keep in mind, I didn't mention, but we have to keep in mind that at least for inotuzumab, the anti-CD22, because the expectation is that this patient may go to transplant, we have to limit the overall exposure to the calicheamicin that the patient they are going to receive in order to minimize the possibility of SOS or VOD. So that is something that definitely is part of the protocol. And I am sure that somebody may question about that, but that is part of the process.
I think Martin wants to.
Just briefly, I wanted to remind everybody that the ALIC group is right now doing a prospective randomized trial using rituximab in CR1. So this may answer the question if it's a useful agent or not.
Thank you.
Kirril, please proceed.
Yeah, and to be honest, the one thing is that each time hematologists used to use rituximab or the other immunological agents, you should think about your poor colleagues transplantologists because we should fight with immunodeficiency afterwards. But it's a joke, sorry. So another very important question is: are there efforts being made to make blina available in low resource setting to adapt the 28-day infusion? This is a question from Hutton Chapman.
Well, this is interesting because before the seminar, we were discussing with Martin through the emails that part of the reason that we would like to focus a little bit in blinatumomab is because there is the possibility that can be requested to the WHO as a medication that is essential to improve the survival. And I think that there is a way that you can request, I think that there is information that you have to fill out and you can request to do it. And between more people and more centers and more institutions request, that will be definitely something that will be an addition as an essential medication for the treatment of ALL worldwide. There is a financial restraint there. Yes, there is a financial restraint. Having said that, I think that we need to look for the support of different entities and governments in order to make sure that this medication that definitely is producing good results in real life situation may be accessible. And we have to learn a little more, as I mentioned, how we can use and perhaps changing the time and changing the days, but it's not clear if that is a real strategy until we can study that possibility.
Just briefly, I fully agree with you. I think it's a great approach that Blina will maybe make it to the WHO essential medicine list. On the other hand, if I looked at your presentation, Cesar, when you showed the overall survival curves of Blina versus chemo in the Gupta paper, it is surprising that the outcome is exactly the same. So it's also a message for resource-limited countries that treating a few relapses more in the chemo group may be cheaper than using Blina in everybody, in particular with 2 cycles on top of chemo. So for me, the future would really be to replace chemo by Blina or other immunotherapies. This will be in the long run cost saving, and because patients are less in the hospital, etc.
Yeah, I think that I agree 100% with you, Martin. If we can use these elements in frontline therapy and we reduce the relapses, the financial situation with the relapse definitely is very, very high compared with increases slightly the economical resources allocated to the primary treatment. That definitely is far, far better.
Thank you. We have another 2 excellent questions, and we decided to briefly conclude about this question. So first question from a great person, Andres Diaz, who is a MD PhD student in the United States. So the question was about the urine test in the limited resource setting for methotrexate elimination. This is a good point, especially in the resource limited setting. And the second is from Dr. Radhris Khan. Sorry. So about the combination of immunotherapy and the infections afterwards. So I've just asked Jelena if I could comment this as sorry, transplant person. So depending on the trial and depending on the experience, but in general, yes, this could be a little bit higher incidence of infections. But as we see as a transplant team, usually the persons who had an experience of combined immunotherapy before the transplant, especially, we could see a little bit higher incidence in the real world of infections. But the general idea of our work is to explain that if you are doing immunotherapy, please be advised and please be ready for the supportive care and the availability of good antibiotics, antifungal drugs, and of course other types of supportive care, such as defibrotide, such as eculizumab, etc., etc., etc. Thanks, and I will pass the floor to Jelena. Thanks.
I will just shortly thank you all because we are 10 minutes over time, but I think 10 valuable minutes. And we managed to answer all the questions. First, thank the youngest one, Joanna, for the nice presentation. The big thank you note for Martin and Cesar for sharing their experience and the whole community experience and the expertise on the specific cases, and Kirril, especially to you for being my back-to-back and moderating this very interesting session. And the last but not least, to Sagir, who initiated this whole educational idea, which I think is becoming more and more recognizable to the whole worldwide community. So thank you very much. Thank you all. And I believe that those ones who could not attend live will really gain the knowledge from the recorded session that we had today. Thank you very much.
Thank you so much, everyone. Thank you, Helena. Thank you, Kirril. Thank you, Martin and Cesar. And
Thank you. Thank you. Bye-bye.
Thank you. Bye.
Thank you, guys. Take care. See you.